Thank you. Okay. And thank you very much for working closely with the Ministry of Health to ensure that this Zoom engagement actually happens. Ministry officials, civil society organizations, including the Soga Health Forum, all senior colleagues on the call, all health workers, ladies and gentlemen, thank you for setting aside time to attend this Zoom, very important Zoom engagement. We are honored to have you on, and we are sure that you will not remain the same after this 1 hour of engagement with a very seasoned physician whom I'll be introducing shortly. Tonight, we are delighted to have him set aside time to share his vast knowledge on hepatitis. You'll get to know more about him. But as Ministry of Health, we have purpose to create awareness on hepatitis in this month of hepatitis. I call it a month of hepatitis because it's the month that we join the rest of the world to commemorate the World Hepatitis Day. And this usually happens on the 28th of July. So this year, our celebrations will be in Kumi district, in Teso sub-region, and preparations are underway. There's a lot that is happening there in terms of community engagement. We are screening for hepatitis. We'll be on media and creating more awareness, and those that test, we are testing, and those that test positive will be linked to care. So we are excited to bring to you a series of virtual engagements on hepatitis as one of the activities that we have set aside in this month of hepatitis. So I urge you to always log on or always participate whenever you're called upon, because we, at the end of this month, want to ensure that health workers know very well whatever our seniors have to pass on in regards to viral hepatitis. Today's session will focus more on adult viral hepatitis, but we promise that we will have pediatric sessions. And next week, we have another very seasoned health worker and a senior colleague who will be sharing with us on pediatric viral hepatitis. So when you see the advert around, please be part and be informed on what is happening. So today, at the end of this session, we'll also hear from our Commissioner Clinical Services, who will be able to give us closing remarks on this very important topic of viral hepatitis. Allow me go ahead to introduce our presenter tonight, who is none other than Dr. George Patrick Akabwai. Dr. George Patrick Akabwai is a consultant physician at the Baylor College of Medicine. He has been actively involved in the hepatitis response since its inception. He participated in the development of our national hepatitis guidelines, and he has led the team in developing the hepatitis strategy 2024-2028 that is going to be launched on the World Hepatitis Day. And we look forward to having this strategy. Thank you very much, Dr. Akabwai, for contributing to your country. And I take this time to welcome you to take us through this very important topic on viral hepatitis. You're welcome, Dr. Akabwai.
Thank you very much, Miriam, for that very kind introduction. Let me share these slides. Can somebody confirm that they can see the slides?
Yes, doctor, we can see them.
Wonderful. So, Ndalamu Isa Mwena Mwena, thank you very much, the Busoga Health Forum, for having me today. Thank you to the Ministry of Health for making this happen as well. I was asked to make an attempt to make a presentation regarding titled Understanding Viral Hepatitis. It's huge. I mean, it's something that you could really do for a very long time, but I will just make an attempt to talk about some of the topical aspects. Some of it is going to be science, but we'll try as much as possible to keep it as basic as possible, but informative, of course. Some of it is going to be program, and some of it is going to be involvement, a call to action by the, of course, we, the healthcare workers, to contribute towards ending and eliminating viral hepatitis as a public health threat by 2030. So my slides cannot move. Yes, so this is my outline. We'll take a look at, remind ourselves about the burden of viral hepatitis, talk about the infection, transmission, natural history, and clinical presentation. I will talk about some aspects of the program implementation. I know my senior colleagues are here. They will allude further to this. We'll look at a bit of testing, PMTCT aspects, treatment guidelines. I have a slide on the new guidelines for WHO guidelines for hepatitis B 2024, and we'll share some take-home points. So important to note that in 2022, WHO estimated that 254 million people were living with chronic hepatitis B, of whom 65% were in the African and West Pacific regions. So you notice that Africa again bears the brunt and the highest burden to hepatitis. Now, this presentation will largely be skewed towards viral hepatitis B, but I will also allude to viral hepatitis C, hepatitis A, hepatitis D, and E. So specifically, chronic hepatitis is a major public health problem and cause of chronic liver disease, and has led to an estimated 1.1 million deaths in 2022, mainly due to cirrhosis and hepatocellular carcinoma. So cirrhosis is simply scarring of the liver, but severe scarring of the liver. And the most dreaded of all the complications that we want to avert as much as possible is prevention of progression to hepatocellular carcinoma or liver cancer. So hepatitis B birth dose is one of those preventive measures that has been mooted and actually rolled out in our country and has been rolled out in the rest of the world and has been observed to have an efficacy of more than 90 to 95% efficacy in as far as reducing mother-to-child transmission of viral hepatitis. But despite all that, it's only 45% of the countries all over the world that are implementing and rolling out a hepatitis B birth dose to scale. We'll get more details as we progress. The WHO's global hepatitis strategy endorsed all WHO member states, that Uganda, of course, Uganda is one of them, to aim at reducing new hepatitis infections by 90% and avert deaths by 65% between 2016 and 2030. So we have a lot of work to do. You have in the previous slides observed that we have lost a number of people to what would be a potentially preventable disease. Viral hepatitis is without a doubt a public health concern in our country. And in 2022, an estimated 1,250 Ugandans died of complications arising from hepatitis B, and approximately 6% of Uganda's population remains chronically infected. 6 may sound like a small figure, but if you compute it to actual numbers, it would certainly should be alarming. Just a quick snapshot of our viral hepatitis situation analysis in our country. Following the Uganda population-based HIV impact assessment 2016, there is a regional variation in the prevalence of hepatitis, and we call that a north to south gradient, because if you look closely, the northern part of the country has the highest burden, while the hills of Chigezi in the southwest have the lowest. So there's an overlap within central, and Busoga is in mid-eastern. You see the prevalence being around 2.1%. But I'm sure there was another prevalence Ufia that came up, and I think that some of those results will be shared. But this just to mention to you that the burden of viral hepatitis is a reality, and we need to do a lot to make sure that we avert the complications arising from this. So this is for hepatitis B. We do not have granular data on hepatitis C prevalence, so we've had regional variations, and again as well, using blood bank results. So we've got through the blood banks, they're able to test. And Gulu and Mbale regional blood banks, the prevalence was about 6% in Gulu and 5% in Mbale. And in Fort Portal, there was also an increase in the prevalence from 1% in 2015-2016 to about 4%. So we have an average prevalence for hepatitis C standing at 5%, which is a huge, something that is of concern to us, and we need to work towards making sure. Of course, there are ongoing studies to give us properly granular data on the true burden of hepatitis C in our country. Important to note is that hepatitis B and C and D take the chronic course. So that's why we are very much concerned about them, because when somebody gets hepatitis, infected with hepatitis B or C or D, they are likely to progress much longer. While hepatitis A and E actually take an acute phase, they are acute conditions and usually happen in outbreaks. So usually symptoms resolve by themselves. So, but I will again have a slide to just talk about that. All right, so into the bit of the science, it's a viral infection that causes inflammation of the liver. You know, the liver is hepato in Greek, and itis is inflammation. So it's inflammation of the liver. And in humans, it's caused by only 5 different hepatotropic viruses. So we have hepatitis A, B, C, D, and E. And they were named this way. Someone could guess, but largely because this was the sequence with which they were discovered. So hepatitis A was discovered before hepatitis E. How convenient. So that is what it is. So all hepatitis viruses can cause acute infection. However, as already alluded to, hepatitis B and C and D frequently cause chronic infections. And yet, so that's why we are very, very much concerned about them. Chronic hepatitis may progress to liver cirrhosis and hepatocellular carcinoma, thus accounting for most of the burden of disease. So treatment, in any case, is aiming at prevention of progression to liver cirrhosis or liver cancer. Some key definitions, how do you define acute hepatitis B? A new onset of hepatitis B infection that may or may not be symptomatic and usually within 6 months. It's usually self-limiting, while chronic hepatitis is persistence. They get acute, but they progress for 6 months or more after the acute infection. So to summarize it, anybody who's had the infection below 6 months is considered to have acute hepatitis, while those, and most times they resolve, the symptoms are self-limiting, while those who get chronic, usually the persistence of the infection is the one that would now really worry us into progression. The highest risk of chronic infection mainly occurs in childhood. If there's any slide that you're to remember, I think this should be one of them, that all our energies, or most of our energies, should be focused to the childhood. And I'll explain why. I already alluded to this. This is not a very nice picture of liver cirrhosis, scarring, and also progressing to liver cancer. All right. So in terms of transmission, I think I already mentioned this. Hepatitis A and E are transmitted through the oral fecal route. So consumption of contaminated water and food are likely to be the cause. So we've had sporadic, or actually very rare, outbreaks. Before, we've had an outbreak in Napak, I think sometime, quite a number of more than 10 years ago. But also we've had, for hepatitis E, we had an outbreak in Kitgum at some point that claimed a number of lives, progressing all the way to Lamor, where the refugee settlements are. So, but this is resolved over time. And so one of the strategies is to make sure that we have clean water, clean and safe water, and we shall avert hepatitis A and E. And that is what the program is focusing on, to ensure, to collaborate with the persons who deal with water, sanitation, and hygiene to ensure that our population is protected. While for the chronic hepatitis B and C, the transmission is usually through blood, body fluids, so vaginal and seminal fluid, so sharing sharp objects and getting into contact with contaminated blood and body fluids could increase the risk. If you notice, hepatitis D is nested in hepatitis B because hepatitis D does not exist by itself. It does not exist alone. It requires hepatitis B for its replication. So it cannot survive alone without hepatitis B. And in the new guidelines, there's a focus on hepatitis D because in addition to, if somebody has a superimposed infection, co-infection between hepatitis B and D, you're actually likely to progress to liver cirrhosis and cancer much faster than somebody who has hepatitis B alone or hepatitis C alone. I think I already talked about this. Occupational blood exposure is important to our setting. Let's be careful about the needle sticks. Some people get viral hepatitis through transplant, the birth to an infected mother. This is a very, very important route of transmission, mother-to-child transmission, and sexual. But also be careful about dental and medical procedures. So infection prevention and control are extremely important. I think I already alluded to this, but this is also a very important slide, one of the most important, just to tell us in the natural history of viral hepatitis, that you can get vertical transmissions from mother to child. And take note, colleagues, that 90 to 95% of infected infants, almost all of them, become chronically infected. So they progress. So if you're to have $1, I think all the dollar should be focused on making sure that we close the tap on this infection because they're the ones who progress. Well, for the adults, 3 to 5% of the people who get infected when they are older than 5 years, only 3 to 5% become chronically infected because with improved immunity, most of the infection is cleared. And that is why we're emphasizing the infant vaccination so that we close this tap. All right. So healthcare workers, please take note as well. We're at risk. So what are some of the myths and misconceptions? Colleagues, hepatitis B is not spread through sweat. Do not segregate against greeting people, sharing clothes, sharing toilets, sharing beddings, sharing foods, drinks, and so on and so forth. Some people I already mentioned this, some people get rid of the infection after exposure to the virus. In this case, the body becomes immune to the infection. And as such, the person will not be infected again because they will have mounted immunity. This clearance of the virus depends on the age of exposure. However, in those who were exposed perinatally, So perinatally, by perinatally, I mean during birth, of course, while it's usually most of the infection for hepatitis occurs from mother to child around the time of delivery. So during delivery and during that period, the contact with the fluid. So 90 to 95% will not be able to clear the infection, and they will lead to chronic infection. Now, you do not want this to happen, or at least you want to reduce this as much as possible. Hepatitis B infection often goes undetected in childhood, as those infections are typically asymptomatic until they present with liver complications. Unfortunately, most people get to know they have hepatitis when they get yellow eyes and they are developing cancer, and we're seeing a trend of young people. In my practice, since the beginning of the year, I have lost 4 patients that I've been directly managing under 40 years due to hepatocellular carcinoma as a result of hepatitis B. So in persons with a depressed immune function, chronicity may be more common, even if they are older than 5 years. So there are many factors that play around. So I think the best is to prevent before it happens. So this is what it is, and I think I already talked about this. This slide just talks about the likelihood of progression to cirrhosis, of course, requiring liver transplant, which is a very rare procedure that you have to book for several years. Liver cancer, of course, and you know the 5-year survival is just 10 to 15%. So hepatocellular carcinoma is one of the most aggressive cancers you can ever have. And usually in our setting, patients rarely survive after 6 months. So we need to avert this as much as possible. Some patients also, of course, if they survive cancer and cirrhosis, they may get liver failure. So many people could present with signs of liver failure that I think we shall quickly mention. But again, it's important to know that acute infection may not be specific. So some people may feel weak, fatigue, so non-specific symptoms, jaundice, and so on and so forth. It's usually good to go and see your doctor. So this is compensated cirrhosis means that the liver has the ability to fight all sorts of potential injury to it. So when the liver is injured, but it's still able to conduct its function, that is compensation. However, when it gets overwhelmed, and that usually happens with high viral load of viral hepatitis, it gets decompensated. And when it gets decompensated, it cannot perform its function. So we get what we call portal hypertension, ascites, a fluid in the abdomen. This is a pregnant man, of course, quote unquote. Some people get esophageal gastric varices. I know there are some people who come to you with portal hypertension and they are vomiting large amounts of blood. And just be sure that you have ruled out viral hepatitis as much as possible. Early childhood vaccination against hepatitis was introduced in our expanded program in 2002. And it starts at 6 weeks, 10 weeks, 14 weeks. So including the intro. Now, recently in 2020, NITAG, I saw if Dr. Akabwai is here, he's, I think, the chair of NITAG. They have introduced the timely hepatitis B infant birth dose into the universal immunization program. And as already mentioned, it's closing the tap on mother-to-child transmission. So let us promote this as we advocate for many, program improvements in the hepatitis implementation. Promotion of safe injection practices, especially among healthcare workers, non-reusable injections, screening for hepatitis B and C, and other transmissible infections. The Uganda Blood Transfusion Services is on board and is supporting in this regard. So our blood we've been given the assurance that our blood is safe because it's screened significantly. I see the team from CPHL here as well, so they could and UBTS. They should give us some further detail. Government commitment politically, without a doubt. 2014, hepatitis was declared a disease of public health concern, and the government has been extremely helpful, supportive, and there was a budgetary allocation of 10 billion a year. And the program, I think, is pushing for more because, as you can see, we need to do a lot more. Ministry started screening and vaccination of the adolescents and adults against hepatitis in 2015, and hepatitis B control activities were implemented in a phased manner based on the prevalence of the disease. So trainings were held for healthcare workers. All the support supervision was done. Of course, there are other support functions like the lab capacity was built. I see the team that built that capacity here. And all adolescents were tested and adults who were born before the year 2000. So those who were born after 2000 were observed to have been, were assumed to have been protected. So those who were born before, there was a mop-up exercise to ensure that all adolescents and adults were tested to ensure that for those who are negative, were encouraged and provided with the vaccine, the vaccine for the adults. Of course, usually given at 0, 1, and month 6. Linkage, those who are positive into care and treatment. I already mentioned that there was a ratification of the infant hepatitis B birth dose into the universal immunization program. And Dr. Jambo already mentioned that a costed national viral hepatitis strategic plan has been developed and will be launched on the World Hepatitis Day. So this is the phased approach that was utilized to train healthcare workers, to test, to increase awareness. So there was advocacy. There were multi-sectoral teams that went to the field. And I know Busoga was phase 2. I was part of this process in Busoga. I supported Mayuge. I supported Ganga and Bujiri at that time. But I'm sure there's still good follow-up that has taken place. And this was basically done based on the prevalence. So we started with the northern aspect of the country, which had the highest burden. So in terms of the program implementation considerations, number 1 is integration. We cannot run parallel programs, so there has been a very heavy move and a very firm move to integrate hepatitis activities into the already existing programs, medical programs. And this, builds on synergies, and those are the benefits of integration. We're dealing with the same healthcare workers, we're dealing with the same population. So we even have, the triple elimination strategy to eliminate HIV, syphilis, and other STIs and viral hepatitis by 2030. So that is the integration. So we do not want to run parallel programs. There's multi-sectoral approach. Of course, there's a strong collaboration the ministry has with other partners, the advocacy, civil society, the academia have been extremely important in the support of the program. The ministries and the MDAs, research institutions, to mention but a few. The implementation has a client focus. Of course, all the services should be differentiated, and the client must get the best, and it should work best, and it should be in the interest of the client. And of course, we cannot overemphasize the need for community involvement, because you cannot, world over, you cannot run a successive program, chronic program, without involving the community. So in terms of who to test, all persons in Uganda should be screened. Everybody should be screened. However, the following categories are at higher risk and should be given priority. Number 1 is the healthcare workers. I know for a fact that the healthcare workers were focused on and the vaccines were provided. I hope it's still ongoing. Students undertaking health-related courses because they get in touch with patients. Pregnant women, of course, people living with HIV, household contacts, and many others, multiple sex partners, people, sex workers, people who inject drugs, and all those categories are people who are at higher risk of getting viral hepatitis. So you may be wondering, am I in a health center too? Will I, what is my scope of work in as far as screening patients for hepatitis is concerned? In a health center 2, 3, 4, general hospital, regional referral, or community outreach, you can at least do the hepatitis B surface antigen as the initial test. You will have contributed and refer the patient. Health center 4s, general hospitals and regional referral hospitals have been supported by CPHL, UNHLS, at least they were with the machines, point of care machines, to be able to manage CBCs, liver function tests, and HIV tests at least. However, I think I saw Viola and Felix on the call, so most likely they could have built even further capacity in this regard. Viral load is through the hub and spoke system that UNHLS is supporting us with, and supporting the HIV program as well, has come in very handy in as far as sensitizing healthcare workers and involving them in the hepatitis programs and all the other facilities. So health center 4s, general hospital and regional referral hospitals are the ones at least who can be able to do additional tests like the E antigen, alpha fetoprotein, abdominal ultrasound scans. But even if they are unable to do some of them, certainly UNHLS has been a great support in that regard. And they can also be able to treat. So Health Center 4, General Hospital and Regional Referral Hospital should have and should be ordering for the antivirals. Categories of treatment, who do we treat? This is the old guidance. I know we have new guidelines, but again, we have to be very, we have to wait for official guidance from the Ministry of Health. The guideline, we have a guideline for hepatitis B and C as a country, 2019, but it's going to be revised. I think meetings are already ongoing, and I think there will be another big one next week. So just look out for any further guidance. So for now, we still have active guidelines that we should follow. Okay, so this just, I mean, I won't go into so much detail about this, but this talks about who do we treat? The categories of people to treat are 3. Category 1, who is eligible for treatment, is if you have clinical liver cirrhosis, evidence of liver cirrhosis, and you have viral hepatitis B, you automatically qualify for treatment. The APRI score will calculate it. I think you're very familiar with it, the index. The APRI score of greater than 2, you must treat. Now, take note that the new guidelines have actually recommended that they have lowered this threshold to greater than 0.5. So this is based on evidence to show that there are some people who actually, when they have an APRI score of 0.5, they already have features of liver scarring. So this is expected to increase the proportion of patients who start on treatment. I'll tell you this, just like we started with the HIV program, we were restricting treatment to a certain category of people. But hepatitis is also moving into the test and treat, but it is moving slowly. So numbers, they're already opening up, and who knows that in fact in the new guidelines, you would see some categories, you just tell them to treat as long as they test and they have other complications. Category 2 is for HIV. As long as you're HIV infected, you must have a hepatitis B test. And if you are, you have HIV and you have hepatitis, you must treat. And the drug that you must take should be the one active against hepatitis. But again, take note in the new guidelines, this has been modified. It has been expanded that beyond hepatitis, just HIV, there are comorbidities, diabetes, metabolic diseases that could cause liver disease, people who are transplant, who are undergoing hemodialysis, transplant patients are a special category that should start on treatment as soon as possible, regardless of the viral load or any other, treatment modalities. Category 3 is the other treatment for those who don't meet category 1. I'm sorry, I'm assuming that you're already familiar with this, but I just want to already bring in some of these insights here. The upper score may appear normal, but the ALT is one of the most sensitive liver enzymes. If it's persistently abnormal, it is defined down here. What a persistently abnormal means. With a viral load of greater than, they must also have a viral load of greater than 20,000 international units. But this has again been modified that for that time we were saying we can only treat if the viral load is more than 20,000. But now it's, as long as you have hepatitis B surface antigen positive, even if your APRI score is low, but you have persistently elevated ALT, and you have a viral load of more than 2,000, not 20,000 this time. So we're capturing even a lower threshold. So we're expanding the category for treatment. There's a conditional category 4, which has been introduced that perhaps I will allude to in the next. It's usually in settings where there is no access to hepatitis B viral load to treat on the basis of persistently abnormal ALT alone. And this recommendation is something we shall talk about at a later time. Very quickly, I'll talk about PMTCT contributing to a huge proportion of patients who are getting hepatitis. This is the algorithm that has not really changed much. So pregnant women testing positive for hepatitis with more than 200,000 copies should receive tenofovir prophylaxis from the 24th week of pregnancy until at least birth. But this has actually been modified even further to say, even if you do not have the viral load and the mother is pregnant, considering that they already have the risk, please treat them. Please, give them prophylaxis and not just wait for 24 weeks. 24 weeks is 6 months. You could just, you do it during, well, it's usually 6, you prefer to give it at the 24th week, at least the second trimester. And these guidelines say, if you look down here, we give the prophylaxis until 3 months after they deliver. However, the new guidelines say, yes, immediately they have delivered, the child has gone through the infancy vaccination, they could stop. However, they're also giving the option for the mother to continue to take her prophylaxis, this time now as treatment, or really you could call it prophylaxis also, but continue for the sake of her health and not restrict her to stop. So there will be an option for her if she wants to continue, especially if she's of reproductive age and will likely give birth to another child. So we're trying to expand as much as possible to ensure people are given the opportunity. I already alluded to this, so I'm going to skip these quickly. So before you treat, please make sure that the basics, good clinical practice, medical history must be complete. A physical exam is important. The APRI score is a non-invasive measure of liver fibrosis and cirrhosis, and it's a recommended method for liver staging in Uganda. So please take note. What drugs do we give? Tenofovir is 300 milligrams for the adults, is encouraged, and entecavir is also recommended, especially for the children who are aged 2 to 11 years, who weigh at least 10 kilograms. So in renal disease, patients should be on entecavir, but also in the new guidelines, they have added tenofovir alafenamide or TAF, which will be made available. It's already, I think they are trying to push it for the HIV program as well, but since we're integrating, we may have it in the near future, certainly. But also the new guidelines have recommended that, because I know for a fact that you may be wondering, you may not have TDF 300 milligram, but you have TDF 3TC or TDF. The new guidelines have actually encouraged that you continue with that. You can give that as an option. Please do not deny a patient who is eligible for treatment a drug. So TDF, 3TC. Initially, there were issues around lamivudine and FTC, but from the evidence, it's a public health approach. We have to cover as much as possible to ensure that we protect the population and intervene as early as possible. But like I already said, I am not the commissioner. I am not the spokesperson of the Ministry of Health. Please await the official communication on the implementation of the new guidelines. When do you stop treatment? Hepatitis B has no cure at the moment, but studies are ongoing in the cure agenda, just like for HIV. They're trying to look for cures for both, but for now, we do not have any cure. So treatment is indicated largely for life. And the purpose for treatment is to prevent progression to those complications I already alluded to slow down the process of the disease, but also to prevent complications. The functional cure exists, but it's a very rare phenomenon where some people may actually along the way clear the infection, but there is a very strict criteria. And this is the criteria that I may not go into, but they can only be, you should have had no cirrhosis, you should have lost that hepatitis E antigen. E antigen is the envelope antigen that is a surrogate for replication. It shows that the hepatitis B is multiplying at a very high rate and usually progresses faster. So it's usually something that you do not want to have. But we can also have some patients who have the E antigen but negative because of a rare mutation, but they're actually actively replicating. So that's why we are we encourage as much as possible viral loads for viral hepatitis for us to be able to know if the virus is rapidly multiplying or not. All right, so to summarize, it's just one slide on viral hepatitis guidelines from WHO that were released on the 30th of March, 2024 in Japan, Kyoto, Japan. The first highlight is expanded treatment eligibility, as I've already talked about, and the inclusion of adolescents. In the past, we used to say adults with cirrhosis and an APRI score of greater than 2, but now it is adults and adolescents. Remember, these are young, these are getting sexually active, and you know, they are literally the near future. They are the future. So you need to treat them and capture and make sure you get them tested as early as possible. This may be a group that already received the pentavalent vaccine, but some of them could have missed. Alternative antiviral therapy regimens have been introduced. So in addition to entecavir and tenofovir, TDF and 3TC are also encouraged as a condition if they are not available. Please, this should be if TDF is not available. Do not just start now indiscriminately prescribing TDF and 3TC. Because you remember also we have resistance developing to these drugs and affecting the HIV as well. So expanded eligibility for antiviral prophylaxis among the pregnant women. I already talked about it. They've expanded the scope. Hepatitis B virus diagnostics. The program is encouraged, WHO is encouraging the use of point of care DNA assays and reflex hepatitis D. Hepatitis B DNA testing, but also this should be hepatitis D DNA testing, because I already mentioned that hepatitis D requires hepatitis B for it to be able to multiply. And it also increases the progression of hepatitis B to cancer and all the other complications. So we have been ignoring hepatitis D. In our country, we do not have, we have about 2 studies that have looked at the Delta virus, very low prevalence, I think of 3%. In a cross-sectional study, Professor Chama did some work as well. Generally, globally, it's about 5%, but the people that are of significant interest are those who have had who have high risk of progressing. In fact, one of the other categories that we are taking note of in the new guidelines, beyond just HIV, is if you have had a family history of chronic liver disease, you've had a family history of your brother, sister, mother, father may have died of cirrhosis, and you have hepatitis B, we shall treat you. Just to be sure that we get you early enough. So that's how they've expanded the program. So Delta virus, hepatitis D has been brought on board. So there are going to be assays, but again, wait for the official guidelines. I think I've already talked about this, testing for hepatitis Delta co-infection, approaches to promoting delivery of high quality services, including strategies to promote adherence to long-term antiviral therapy and retention in care. Adherence. We may treat, give the best treatment, but if the patients do not take their medicine, then we're in trouble. And of course, I can't overemphasize the need for retention in care so that we're able to follow the cohort. So again, please wait for the guidance from the Ministry of Health. And again, implementation of recommendations of guidelines. WHO has given a disclaimer that this implementation of the recommendations in these guidelines should be informed by local context. So we're going to look at the local context, including hepatitis B epidemiology. We want to see, we have a new sero survey. Do we have an increment in the number? Have we had a decrease in the number of patients? All the interventions we've tried out before the pentavalent, have they worked? So that's some of the information, that's local context. Prevalence of other comorbidities, availability of course, resources. So funding, we have to look at that. So all those things will be discussed during the guideline development revision for the country. Of course, the capacity of the healthcare system and anticipated cost effectiveness. These days programs, I mean, like it has always should always be, there must be health economics involved to cost programs. Okay, I already talked about this. So prevention is the mainstay of treatment and vaccination, immunization or vaccination for hepatitis B is the mainstay of prevention. So it's the birth dose, the infant birth dose is encouraged within 24 hours of birth or at the earliest opportunity before 7 days postpartum, because beyond that, the efficacy dips. There will be a missed opportunity. And remember, it's efficacious to 95%. So 90 to 95%. So you don't want to miss that opportunity. And we're opening it and not saying only for mothers who are to infants. It's supposed to be for all infants across the board, regardless of the mother's hepatitis B status. So this is one of the inclusions to the expanded program. But the team from NITAG and UNEPI, certainly Dr. Jambo would be in a better place to give that update. All right, so pentavalent vaccine has not been stopped. We are continuing with it at 6 weeks, 10 weeks, 14 weeks. So during our advocacy, during our radio talk shows, we should be talking about immunization, because that is the mainstay. And inadvertently, it prevents the Delta virus as well, hepatitis D, from wreaking havoc. So vaccination of individuals in all susceptible groups is important, and we use the monovalent vaccine. Healthcare workers, of course, I hope you are vaccinated after testing. HIV-infected persons, these are categories that should really be prioritized for vaccination. Because again, we cannot vaccinate everybody who is negative. But again, that's an issue that civil society was concerned about. But if you're pushed to the wall, at least focus on the high-risk groups. But please do not deny the population a service. If somebody comes to you to test for viral hepatitis, do not deny them a service. You must test them. What are the take-home messages? Colleagues, there is no virologic cure for hepatitis B to date. Please take note that hepatitis C infection is curable using directly acting antivirals, DAAs. And I must tell you that the current guidelines we have actually are for hepatitis B and C, but we haven't officially implemented the hepatitis C guidelines, but it is top on the agenda in the new strategy. The current goal of treatment is to prevent viral replication and further damage to the liver, as measured by undetected viral load levels, improve liver histology. Pre-treatment assessment is important. I can't overemphasize the requirement, the need for this. Let's take note that hepatitis A and E mainly occur in outbreaks, as transmission is through the orophycal route. So symptoms often are acute and are self-limiting. So strengthening water sanitation and hygiene interventions are the mainstay of prevention of viral hepatitis A and E. So National Water, Ministry of Water, those organizations that support with safe water, working with the districts to make sure that we have hygiene is extremely important. And ministry is working with the different aspects in the decentralization process. All right, hepatitis C is curable. And yes, the national guidelines are very clear on that. And maybe the commissioner will update us on how far we are in terms of management and implementation of the hepatitis C virus program. Colleagues, I would like to acknowledge the Ministry of Health for making this happen, WHO, PEPFAR Global Fund, the Busoga Health Forum for making us share this presentation, civil society organization, very, very important group of people that are selflessly really working so hard to ensure that every Ugandan has the opportunity to get a service and, gets tested, gets a service at least, and maybe avert progression to to cancer and liver failure. Healthcare workers, of course, are very, very core in this fight. I must salute them, Baylor Foundation Uganda, and all the partners. I mean, the list is endless, but and to thank you all for listening to me on a Friday evening. And I will be happy to answer any questions. Thank you very much.
Great presentation there from you, Dr. Patrick Akabwai. Thank you so very much. And I see appreciations in the chat. Thank you so very much. I know you're not in Uganda currently, but you've made it a point to reach out to the health workers here in Uganda. Thank you for loving your country. I'll go right away to the concerns that will be raised by the participants. Kindly, we'll take a few questions or concerns. I see quite a number in the chat. I'm trying to see if there's a raised hand. I saw someone like Kansime had raised a hand. Just unmute and ask your question quickly. We are running out of time. Then I will read from the chat also. Thank you.
All right. Thank you, Doctor, for the presentation. Been really waiting for this presentation as I manage hepatitis patients in my clinic every Friday. I'm happy to hear that the new guideline has come up. I just needed to know if we are going to, starting my next week, will I start putting this in practice? And if I do so, my number one question is about the first category, where now the to the point. If it is only because I've seen it being combined with evidence of liver cirrhosis, greater 5 from reaching Ghana pre-score of greater than 0. No evidence of cirrhosis. My second question is about if the hepatitis viral load has now changed from 20,000 copies to 2,000 copies. Is it quite the same about the pregnant women? Is it still about 2,000 or the prophylaxis is given to those that have 20,000. I saw that difference. My last question is those that have taken the acute phase, and we have said that after 6 months, if the hepatitis, is it surface antigen, when it stays positive, we decide that these ones are now chronic, chronic infections. So I've had many questions of, now doctor, how do I know I am healed or I'm not taking the route of chronicity? How do I determine that this patient is now healed, the body has fought the infection, is not a chronic patient? Those are the three I would want to understand. Thank you.
All right, Doctor, let me also, I don't know if you've read some of the concerns from the chat, but I could just read out a few.
Yeah, that would be helpful.
Okay. So Dr. Fozia asks, appreciates the presentation and asks what's the rationale for waiting for two weeks if the birth dose is not given within 24 hours is, I think you alluded to that, but you make a comment. And then we also have Dr. Muyimbo Timothy saying, thanks, great presentation. For healthcare providers, it's very important to get all the doses of the vaccine correctly and as scheduled in order to mount an adequate immune response. Also, it is a practice to check the anti-hepatitis B and surface antigen and antibodies. Okay, to check the antibodies in Uganda. Is it a practice to check the antibody titers in Uganda to ensure one has made more than 100 copies, in which case the response is protective? You will be surprised at how many even after the vaccinations may not mount these. So there is a question and also a comment in this. For those who have managed to get liver transplant, is there a need to continue the anti-hepatitis B treatment? There are other questions up. Let me just scroll up. Sorry. You could be responding to those as we read on.
Okay, a couple of questions, very interesting and important questions. The colleague asked about, and thank you for the work that you're doing. We are seeing our patients. She asked 3 questions. I didn't quite get them all, but I think because of the internet connection on her side. I think the first question was on the APRI score. I think why they change from 2 greater than 2 to greater than 0.5. And I think I mentioned that this is important because it studies. I think there were about 15 systematic, they conducted quite a number of studies on and comparing which APRI scores would be appropriate, would be synonymous with liver scarring. And in the last, I think 2 years ago or a year ago, when we had the hepatitis conference in Kampala, some information was shared from, I think, Egypt, and it already alluded to many patients presenting with cirrhosis, but having an APRI score less than 2. So that is what motivated the discussion. And I must notify you that the WHO guidelines committee is multisectoral and it uses a graded system. So some of the evidence is based on studies, a meta-analysis, systematic analysis, systematic reviews and meta-analysis. but also it's based on expert opinion. So there are grades. So the level of evidence depends. So most of these guidelines, if you understand policy, when you're making policy, usually the level of evidence would depend really. So yes, it is 0.5, and it's a good opportunity, I think, in my opinion, because you're catching this early enough. Because most times patients above 20 already have cirrhosis, so we shall be missing out there on the opportunity. You asked about the guidelines, please. My commissioner is here. I think I saw two commissioners. Dr. JB, I think, was also here, and Ronnie is also here. Certainly, Miriam is here. Please wait for guidance on when the new guidelines will come. Those were WHO guidelines. So the technical working group, the working group for hepatitis for the country is, and of course, the other sectors are going to discuss this. And I told you about the disclaimer. So please await the guidance on implementation of the guidelines. So for now, implement as you according to the current guideline. You mentioned about 200,000, the copies for the pregnant mother. Yes, so initially it used to be 20,000 copies for category 3 with abnormal ALT, but now it has been reduced to 2,000 copies. Again, we're catching this early. When the viral load is low is when we should be able to treat these patients, because again, they compared patients and the outcomes and realized that there was a benefit in treating patients earlier and catching them earlier to prevent and to avert progression to end-stage disease. Dr. Muyingo asked about, of course, it was a comment, healthcare workers, please get vaccinated. Firstly, get tested. Some of us were vaccinated before testing. Then you say, oh, but I tested. You test after, and then you say, but I was vaccinated. So it's likely that you tested already. You already infected before you got vaccinated. And please complete the vaccine schedule. It's very important because that gives you, I mean, in terms of efficacy, it offers you protection. The studies already show that you're protected for a very long time. Some studies, not specific, some studies have said you're protected for more than 30 years. Others say much longer than that. So there is no compelling evidence to require booster doses. However, in individualized kind of management, patients who are at highest risk, the patient who receives large amounts of blood, hemodialysis, organ transplant, this is a patient that perhaps you would want to give a booster dose. But for you, you may not require it because you're protected. In terms of being able to do the titers, it's not common practice, but it's a good thing. For some countries, when you're going for their visas, they ask for, have you been vaccinated against hepatitis B? And they will ask for your viral load. They will ask for the titer. So if you have the anti-HBS, which is more than 10 international units, you're protected. You're still protected. But they also, I mean, CPHL could be able to help. For the healthcare workers, I'm sure you could be supported by CPHL to be able to do some of these markers if they're able to do so. So those who will have liver transplant, do they continue with the treatment? A very interesting question. Liver transplant is a very complicated subject. So the treatment is dependent. Yeah, because yes, they will have to continue with the treatment because they still have ongoing infection in their system. It's just the liver that was hit and was taken out. But the underlying condition is still there. So yes, they will continue with the treatment, but of course it gets more complicated because if you have a transplant, you are on immunosuppressive drugs for a very long period of time. So it's something that we do not want to get into. So let us prevent us getting into liver transplants or our patients getting into That's if you're even able to afford it. Many people are not able to afford this procedure. Over to Miriam.
Okay, so just maybe some few quick ones. Explain about a hepatitis B envelope antigen. That is from Eric. David Luvega says, what do you do for one who turns negative after being treated for 1 year? Then Rio asks, what does hepatitis B surface antigen positive imply in a fully vaccinated? I think you already mentioned that it could be that they had the infection before vaccination. So if I'm hepatitis B positive, what steps do I take and where do I get the treatment? I think that's we could respond to those.
All right. Thank you very much. E antigen is the envelope antigen, a very important marker of multiplication of viral hepatitis. So, a virus which is multiplying rapidly exposes us to progression. It increases the likelihood of you progressing to end stage renal, liver disease as fast as possible. So it's a measure, it's a surrogate measure of the multiplication ability of the virus. So it's something that you need to look out for. And that's why we have put it very clearly in the guidelines. We need to look out for it. CPHL is able to do that. However, there is a small proportion, maybe less than 1% of the population that has a mutation against the E antigen. They may not show it, but they're actually multiplying, and that's why we do it together. We usually prefer to do it together with the viral load, so that we're able to really quantify objectively on how the virus is. And again, it's similar. The goals, like in the HIV treatment, the goal of treatment is to reduce, to achieve virologic suppression and to maintain it for as long as possible. Because if it is low, if the viral load is significantly low, then the liver is protected. Otherwise, the hepatocytes will keep getting injured and they easily get cirrhosis. So that is what it is. Where do I get treatment? I think you should look out to your, for your nearest health facility. You should be able to get treatment in a health center 4 and higher. But please go through, get the support all the way from the health center 3s. You should be able to get supported. Please reach out to your nearest healthcare worker to be able to guide you. Please call Dr. Jambo if you're stuck. She's at the ministry, so she will be able to direct you on where maybe you could go. Yes. Did I leave any question? Oh.
There are so
So
many
many.
concerns.
Yes.
I don't know what Benjamin has to say because our time is out. But we need to invite the commissioner to make his closing remarks. But maybe just 3 more. Do we give all pregnant women prophylaxis with the hepatitis B surface antigen positive or only those with viral load of 20,000? Okay. Then, well done. Any protection for sexual partners of hepatitis B positive individuals already enrolled on medication? Has the immunization already in progress for infants with within 7 days postpartum? Then how do we handle hepatitis B surface antigen patients in pregnancy? Some current updates. Okay. I hope you pick what the participant is communicating. So let's respond to those. Someone also wants your contact for consultation. Great presentation.
So thank you very much. I have displayed the algorithm for the PMTCT. So if the mother is pregnant, she must have hepatitis B, HIV, and syphilis test as a must, as part of the triple elimination. So we do the E antigen and also the viral load, if available. And again, this has been, please do not stick. So the new guidelines actually open this up. That as long as you're pregnant, you may not wait for the viral load of more than 200. Okay. We encourage, because people with pregnant mothers with a viral load of more than 200,000 are more likely to infect the baby, to transmit the virus to the baby. So usually we encourage that at least the pregnant mother gets she's a priority in the priority group. So she should get a viral load. I'm sure CPHL is very efficient in that, and should have the e antigen, because that will give us an indirect surrogate for multiplication. So prophylaxis should be initiated at 24 weeks, although of course, yeah. So we initiated at 24 weeks and continue until she has delivered and the baby has completed the pentavalent. So around 14 weeks, this old guidance says 24 weeks could go. But again, one thing that the new guideline has added is that the mother has been given an option if she so wishes to continue, because it's the same treatment. TDF is the same drug we're using for treatment. As long as she's hepatitis positive and she wants to continue treatment because of her health, she is permitted to do so. The old guideline does not allow that. So that's what we do. So pregnant mothers are extremely important. So how do you manage a pregnant mother who has hepatitis? So this is the treatment. You treat them, but of course it has to be individualized because it changes, of course. I mean, it's similar when she has delivered to the other population. So we monitor them. So as long as somebody tests positive for viral hepatitis, they don't have to be treated. Those categories apply. So please, some people just require monitoring. So you must monitor them. And the schedule for monitoring, I think, has been shared. Don't take 6 months without reviewing these patients. And there's a list of the tests that you do whenever you're to review these patients as much as possible. But pregnant mothers are a special category because PMTCT contributes a great deal to mother-to-child transmission.
Okay, so what's your comment on hepatogenic medication? Just one last one. This series will continue, colleagues, and we'll be able to.
I will be happy to come back. Maybe after we have released the guidelines, then we'll talk about the guidelines now in detail at a later opportunity. But certainly be very mindful of those drugs that you have called the hepatogenic drugs. Be extremely careful, but also anything that would be, would potentially insult the liver. So alcohol, herbal remedies, there are many of these commercial drugs that are being promoted. I will not mention them, but be very, very mindful about that, because that could increase your likelihood of progressing to chronic liver disease and complications. So be very, very, very mindful of your liver. And that's the message you should always give the patients who test positive for viral hepatitis. Please do not stigmatize against them. I think all those aspects have been discussed. There is care available, and they should be able to be supported. Thank you.
Okay, there are so many concerns. I apologize if we have not addressed your concern, but kindly park the concern. We have a series of engagements, and we'll be coming back later with more sessions. Allow me at this point to say thank you very much, Dr. Akabwai. We are so grateful. Thank you for sharing all this information. And we know you share more even as we update the guidelines and disseminate them. We'll be very glad to continue to learn from you. And I see continued requests for your contact, so you could decide whether you want to share the contact with the colleagues on the call. Colleagues, allow me welcome the Commissioner, Clinical Services Department at the Ministry of Health, and that is none other than Dr. Ronnie Bahatunjire. Dr. Ronnie Bahatunjire, you are welcome to speak to the audience here. Thank you.
Thank you so very much, Miriam, and good evening, colleagues. I kindly request that before I give my closing remarks, I invite my colleague who is on the call, my senior colleague who is on the call, Dr. Jebi Maniaye, to deliver his appreciation remarks since he has attended the whole entire session from the beginning. Dr. J.B. Wanyai, please speak to the audience. We have had 165 participants to this webinar tonight. So please, you have the floor. Dr. JB?
Can't hear.
Dr. JB Wanyai?
I don't think he's able to unmute. I'm not sure. Maybe.
Commissioner, we can't hear doctor.
Yeah, it's very well. I was calling on Dr. Wanyai to speak to the audience as a senior colleague who has attended the whole entire session from the beginning, just to make sure that we all are well represented as the two different constituencies. Dr. Wanyai represents the Emergency Care Services Department, Emergency Medical Services Department, and therefore I request kindly that he speaks to the audience in appreciation of the webinar that has just been presented.
Thank you, Dr. Ronnie, and thank you, our chief presenter, Dr. Akabwai, and the moderator, Miriam, and the Soga Health Forum for this nice webinar. I have personal interest in viral hepatitis because I've lost a brother due to hepatitis B virus. And so I tend so much to follow whatever developments are in place. I want to just join Ronnie and the team to say we are very grateful to this discussion which has just taken place and for the education which we are getting as Minister of Health. We so much value these educative programs. And Dr. Ronnie and team, thank you. Soga Forum, thank you, and all the participants, thank you. And thank you for giving me this opportunity to say what. Well, thanks.
You're welcome, Dr. Wanyai. Colleagues, Dr. Wanyai is the commissioner in charge of emergency medical services at the Ministry of Health. And as he has indicated, he deals with emergency situations. And in the emergency situations, we have many a time patients that we evacuate from scenes of accidents when they are bleeding. And that could be one of the risks or the risk factors for transmission of hepatitis B amongst healthcare workers, if especially we are not vaccinated. So it's important that we all are on the same team when it comes to advocacy for prevention against hepatitis B. But all that said, allow me extend my sincere appreciation to our facilitator, Dr. George Patrick Akabwai, who has elaborately taken us through this webinar tonight. Dr. George Akabwai, if it were possible, maybe we could all open our microphones and we clap for George. He has done a very tremendous job. Thank you so very much. And for the Soga Health Forum that gave us or availed us this opportunity to be able to reach out to healthcare workers and to all those that have been able to join in on this call. Thank you so very much. This is a very good platform that you've availed us to be able to reach out to so many of our healthcare workers, especially in this month that we are seeking to join the world to commemorate the World Hepatitis Day. As has been already indicated, there is a lot of information that healthcare workers may not be aware of or may be aware of, but we tend to negate and we find ourselves getting exposed. And we feel through such platforms, we are in position to continually drum up support toward knowledge acquisition, skill acquisition on how best we can prevent ourselves from being exposed, but then better still, even preventing our patients that we care for from contracting hepatitis B from our healthcare facilities, especially during the times when we are dealing with other patients that potentially could be presenting with hepatitis. And we believe that for all of us that have been able to make time to participate in this engagement today, we were up to 165 healthcare workers. There has been an element of knowledge acquisition that has happened today and or tonight. And we believe we are going to be better people. We are going to be able to reach out to our colleagues that have not been able to participate in this webinar, and we will be better practitioners going forward, and we will be able to serve better for those that come to seek for services from us. Colleagues, allow me appreciate all of us once again for making time to participate in this webinar, and allow me call upon us to ensure that we do whatever is within our reach to ensure that we are able to prevent against transmission of hepatitis from one person onto another, especially for the preventable hepatitis B. Dr. George Akabwai put a question to me on the implementation guidelines of the new implementation guidelines against hepatitis B in the country. And I must inform us that the new strategic framework has been developed and it has been approved. And it's against this premise that we're coming to you, all of us here, with this new information. And it's upon approval of these documents, especially the strategic framework, that implementation guidelines are developed. So we are going to now get into the next phase of updating our guidelines. And once these guidelines are ready, they will be shared with all of us, and we'll be able to go ahead and implement them. But in the current, let us go ahead and implement as per the old guidelines that are existent. We have a reference to make with the global guidelines that are approved of by WHO. But then we also have the Uganda clinical guidelines that has a very resourceful topic on management of viral hepatitis. Let us use these documents that are available to us to ensure that we manage our patients appropriately without exposing ourselves as healthcare providers, but then also not exposing the patients that come to seek for these services from us. And I must say that we have been a very wonderful audience with immense questions that have been asked, which is a clear testimony that we were hungry for this information. And George, you've done a very great job in ensuring that we do a very good session today, and you have been able to enlighten us. And I believe we're going to go home better people, and we will be better practitioners going forward. Without losing much time, allow me on behalf of the Minister of Health, appreciate all of us that have taken time to participate in this webinar, and wish all of us a very wonderful evening and a very wonderful weekend. Thank you and good night.
Thank you very much, Commissioner. The Commissioner Clinical Services Department. This is the department that houses clinical care and management of these patients with viral hepatitis. Thank you for supporting these calls. Allow me hand over to Benjamin from the Busoga Health Forum. Thank you.
Thank you so much, Dr. Miriam, and thank you so much, Dr. George, for this wonderful presentation. Thank you to our commissioner who have joined. To make it to clarify, we have had a maximum of 200 participants online, and we are proud for this. I want to take this honor to appreciate Dr. Akabwai George Patrick for giving this remarkable presentation at on this forum today, the 5th of July. And on behalf of Busoga Forum, kindly take this appreciation certificate in good faith. And whenever we invite you, we shall be grateful to have you make a presentation. And Dr. Miriam, you have been a wonderful moderator. Your participation and your activeness has kept us active throughout the whole session. Thank you so much for moderating this session. I'm humbled. Thank you so much.
All right. Thank you for the certificates, the Busoga Health Forum.
Thank you very much.
Dr. Akabwai, you want to say thank you?
No, I'm done. Really, thank you very much. And certainly looking forward to coming back. I will be happy to share any other information whenever I'm asked to do so. I like to share information. So thank you. All the best.
Okay. Thank you very